Okay, I'm going to go ahead and get started. Good morning. Well, it's morning where I am. Good afternoon to you all. Good morning. Welcome to today's session, and thanks for joining us to discuss the independent dispute resolution process. I'm Laura Tolan. I'm a senior editor at Health Affairs, and I manage our Forefront series, which is called Provider Prices in the Commercial Sector. For both the series and today's webinar, we are very grateful for the support of Arnold Ventures. Before I get started, I want to alert you to 3 new Forefront articles. That's the next slide, I think. The next one, yeah. Just want to make sure you all are aware there's 3 relatively new articles. One just came out this morning that are relevant to today's conversation. And we're going to drop those in the chat as well, so you can check those out. I am going to introduce your Master of Ceremonies in a minute, but before I do, just a little bit of housekeeping. During the webinar, questions can be submitted through the Q&A tab at the bottom of the screen. You don't have to wait until the Q&A period to type in the questions, and you should just feel free to put those in at any time during the presentation. And then Jack, as our Master of Ceremonies, will be reading those out at the appropriate time. I also want to mention that today's session is being recorded, and both the video and the slides will be available on our site, healthaffairs.org, under the Events tab very shortly after the event. So next, I'm going to turn it over to Jack Hoadley, who will moderate the session. Jack is a research professor emeritus in the Health Policy Institute of Georgetown University's McCourt School of Public Policy. And before that, during a long and illustrious career, Jack has served 2 terms on MedPAC and has had positions with the HHS Office of the Assistant Secretary for Planning and Evaluation and the Physician Payment Review Commission. And with that, I thank you so much, Jack, for doing the honors today, and I'll turn it over to you.
Well, thank you, Laura. Appreciate that. And thanks to the entire Health Affairs team for inviting us for this webinar and for making all the arrangements. And thank you to Arnold Ventures for supporting both the webinar and much of our work on this topic. I'm going to take just a moment or two to give you a little bit of background. I don't want to assume that everybody's completely familiar with the No Surprises Act, and then I'll introduce our 2 initial presentations. So the No Surprises Act is actually approaching the 5-year anniversary of its passage. It passed in 2020 in December, and we're in the 4th year of implementation of all the protections and the components of the legislation. The law and its implementation reflect a broad consensus for protecting consumers in 2 key scenarios: those of emergency services, including air ambulance services, and non-emergency services that take place in network facilities. There's been less agreement on how best to determine payments for non-network providers in these scenarios, and that's a lot of the focus of today's session. The law requires an initial payment or coverage denial by the plan to the out-of-network provider. Then there's an independent dispute resolution, also known as IDR or arbitration, process that's available when providers are dissatisfied with the payment amounts that they're provided by the plans. When private negotiations between plans and providers fail and IDR is requested, then both parties will file payment amounts that they're interested in paying or receiving and justifications for those amounts. And then in what's called baseball-style arbitration, the IDR entity or the arbitrator selects one amount or the other and makes that determination. So with those basic background facts, let me turn to our 2 initial presentations. Both are being made by wonderful members of our Georgetown team. First, summarizing our analysis of the IDR data, is Kenna Watts, a research fellow at the Center on Health Insurance Reforms in Georgetown's McCourt School of Public Policy. And then she'll be followed by Katie Keith, who will describe the litigation that's been a major storyline since the law passed. Katie is director of the Center for Health Policy and the Law, and that's part of the O'Neill Institute at the Georgetown Law School. So with that, I'll turn it over to Kenna.
Great. Thank you, Jack, for that overview of the NSA and the IDR process. And I just also want to give a big thank you to Health Affairs and Arnold Ventures for supporting this webinar today. If you wouldn't mind advancing the next slide. So as Jack mentioned, we'll be diving into litigation and we'll also have a panel later on. But before we get there, I wanted to walk through how we're seeing the IDR process play out and provide a sense of if or how implementation has really gone as intended. And so to do so, I'll be sharing information on the total cost of the IDR system, as well as trends we've seen in volume, provider plan participation, payment awards, and more. And this analysis draws entirely from the public use files published by CMS, which includes quarterly data on resolved disputes. Next slide, please. So we're going to start things off with a bit of sticker shock today. So in the first 2.5 years of the IDR process, we estimate that the system has generated more than $5 billion in total costs. And this is roughly equivalent to $2 to $2.5 billion spent each year on the arbitration process alone. And as you can see in the graphic on the slide, these costs include 4 key components: administrative fees, IDR entity fees, parties' internal administrative costs, and payment amounts that exceed in-network rates. So just to give a brief overview, the administrative costs are what keep the system running, and these are either paid to the federal agencies or the IDR entities. And as you can see in the graphic, these are the smallest share of total system costs. The second largest contributor to costs are parties' internal administrative costs to initiate, respond to, and prepare disputes. And this amount includes both provider and plan costs and is an estimate that was published by the agencies prior to the initiation of the IDR process. And as you can see in the graphic, the final and largest contributor to IDR costs are payment awards that exceed in-network rates. And so to estimate this roughly $2.24 billion, we compared the QPA as a proxy for initial plan payment and in-network rates with the prevailing party offer, which is the payment determination as decided by the IDR entity. And in nearly all cases, this difference between the QPA and the prevailing offer represents additional payments made or to be made by plans to providers. And I just want to be clear that our estimate assumes that all currently unpaid resolved cases will eventually be paid. Next slide, please. And so this raises the question, how did we get here? How has the IDR system incurred billions of dollars in costs in just 2 years? And the answer largely comes from a high volume of disputes, and disputes that are primarily initiated and won by private equity-backed providers and are won at determinations at high payment amounts. And not only have these trends led to billions of dollars in costs, but they've also hindered an effective IDR process. And I'm going to explore each of these trends in more detail for the rest of the presentation. Next slide, please. So first, we can see that the volume of disputes continues to surpass agency estimates by millions. And the regulations that establish the IDR system, the federal agencies estimated that the process would annually resolve approximately 17,000 disputes, with an additional rough 5,000 disputes for air ambulance providers. And you can see this totaled estimate in the first bar on the graphic. And this estimate reflected the expectation that most disputes would be resolved amicably between the parties through a mandatory 30-day negotiation period before IDR. And the rules also anticipated that stakeholders would submit payment amounts cautiously because, as Jack described, the baseball-style arbitration and the loser pays fee approach. But this expectation has not played out. Instead, the last 2.5 years have shown a much different reality. More than 3.3 million disputes have been filed to date, as you can see in the second bar on the graphic. And of these closed cases, IDR entities have issued payment determinations for roughly 3/4, and the remaining fourth have been closed for reasons such as ineligibility, withdrawn by the parties, settled by the parties, or closed for data entry errors. Next slide. And we've seen that this volume is largely driven by providers as they flood the IDR system and initiate the vast majority of disputes. The graphic on this slide shows the total disputes submitted in each quarter. That's the navy blue bar. And the lighter blue bar represents the share of cases initiated by providers. And as you can see, in all 8 quarters with PUF data, providers have initiated at least 85% of disputes. And in Q4 of 2023, this hit a peak of 91% of disputes initiated by providers. Next slide, please. And in addition to submitting the majority of disputes, providers are winning most. Across the 2-year period, providers have won 82% of all cases, though as you can see in the graphic to the left, this share of cases does vary quarter to quarter. And not only are we seeing providers win more often, but we're seeing them win at much higher amounts than plans. As you can see in the graphic to the right, in 2024, providers won a median amount of approximately 450% of QPA. This means that the provider requested and won a payment that was over 4.5 times the median in-network payment rate for that service. And this was also likely the original amount paid by the plan. And as you can see in the graphic, this amount has grown over time. If you look at the lighter blue bar in the graphic to the right, that represents median awards in 2023. Compared to 2024, there is a significant difference of about, and we've also seen that while plans have also experienced some growth in their win amounts, this is on a much smaller scale than providers. As you can see in the plan win section of the graphic, in 2023, the median prevailing offer for plans was 100% of QPA, and this is likely a proxy for their in-network rates. But in 2024, plans median prevailing offer increased to 110% of QPA. But despite this increase, it's clear that providers are still winning at substantially greater amounts than plans. Next slide, please. And this provider's success is primarily concentrated to a few private equity-backed groups. In fact, 5 private equity provider groups account for almost 2/3 of disputes, as you can see in the pie chart to the left. And these groups include Radiology Partners, Team Health, Halo MD, AGS Health, and SCP Health. And while Radiology Partners and its affiliates has remained one of the more frequent users since the inception of the IDR system, we've seen that third-party entities like Halo MD have quickly risen in prominence. In 2023, Halo MD accounted for less than 1% of claims, but by the end of 2024, this party was the 3rd most active participant in the IDR process. And we've also seen these top private equity-backed provider groups secure much higher payment awards than the overall median awards. As you can see in the graphic to the right, the dashed lines represent the median payment award across all disputes, whereas the bars are for individual provider organizations. So as you can see, Radiology Partners and Halo MD both outperform the overall year medians. And in 2024, the median prevailing offer amount for Radiology Partners was approximately 570% of QPA, while Halo MD's was 770% of QPA. Again, this is compared to all disputes with a median of 370% of QPA. And in some quarters, we see that this amount is even higher for some provider groups. For example, in Q3 of 2024, the median award for Halo MD was 1,030% of QPA. That is more than 10 times in network rates. And so this involvement of private equity in the IDR process through providers and middlemen, and in addition to a potential private equity-backed arbiter, really raises concerns that entities may be strategically manipulating the IDR system for profit. These same groups that fought tooth and nail against the NSA may now be the ones most profiting from it. Next slide, please. And in addition to this high volume leading to high costs, it has also led to some unexpected process issues, though we have seen some slight improvements be made. I'm going to quickly touch on 4 primary process issues we've seen in the last 2.5 years, including the backlog of cases, the share of ineligible claims, variation among IDR entities, and high days to determination. So we'll start with the backlog. As you can see, in May of 2025, in the graphic to the left, the majority of cases have been closed, approximately 85% of all cases, which is a substantial gain from the 29% that was closed at the end of the first year. And this is likely because the IDR system was not intended to see such a high volume, which led to low case closure rates as the system adjusted. But it appears that now the system has learned to cope with these high volumes and has cleared the backlogs. Similarly, the share of ineligible cases has also been reduced, and I would go as far as to say it's been cut in half since 2022. And you can see this reflected on the graphic to the right. And this reduction in ineligibility could reflect a better understanding of case eligibility from the disputing parties, though it is important to note that almost half, about 42%, of cases continue to be challenged as ineligible. Alternatively, this reduction in ineligible claims may be the result of misaligned incentives. Since IDR entities are only paid for eligible claims, and these entities determine eligibility, They may be incentivized to rule more cases as eligible than ineligible. Next slide, please. And in addition to potential misaligned incentives, variation across IDR entities also raises concerns about the IDR process. This graphic on the slide shows you the difference in determinations ruled in favor of providers by IDR entity. And you can see that 4 entities ruled in favor of providers in more than 90% of disputes resolved in 2024. And for 1 entity, this share of disputes was as high as 99%. On the other end of the spectrum, 1 IDR entity, the one that had the lowest share of cases ruled in favor of providers, found disputes in their favor only 19% of the time, and that was in 2022. And while this increased moderately to 30% in 2024, there is still this substantial difference between less than 1/3 of cases to nearly all cases being ruled in favor of providers. Next slide, please. Furthermore, days to determination also varies significantly by IDR entity. While in 2022, the average days to determination across all entities was 131 days, this overall average did drop significantly to approximately 60 days in 2024. But despite this drop, only 1 entity had an average close to the statutory requirement of 30 days. So you can see that requirement on the graphic in the dashed yellow line, and then the days to determination by year and by entity in the bars. Next slide, please. And despite these differences amongst IDR entities, across disputes, we've also seen slight improvements in the days to determination, although it's important to know that these modest reductions in average days are still more than 3 times higher than the statutory requirement. And in Q4 of 2024, only 22% of batch cases and 34% of single cases were resolved within the 30-day deadline. Next slide, please. And so how do we make sense of this all? I think it's maybe helpful to start with the positives, and that is undoubtedly that the NSA has protected consumers from egregious surprise medical bills. And preliminary research is also indicating that the NSA has led to cost-sharing reductions for consumers as well. And while the IDR process has not been implemented entirely as intended, we see that improvements are being made to the system. But despite these improvements, this system is costing billions of dollars a year and warrants rethinking. Without change, these high costs could ultimately be passed down to consumers. Next slide, please. So thank you so much for your time today. I welcome any questions you might have. Feel free to submit them in the Q&A feature of the webinar. And with that, I will pass it off to Katie to give us a rundown of litigation around the NSA.
Thanks so much, Kenna, and would echo the gratitude to Health Affairs and to Arnold Ventures for the opportunity today. I'm here to talk about the litigation, which I think Jack might have referred to as a saga, which is certainly true, and to provide, I think, frankly, some additional context to some of the data and information that Kenna just shared about the IDR process. And one explanation that we might have for why the outcomes are looking this way, I think, stems from the quite aggressive litigation we've seen over the No Surprises Act. So if you go to the next slide, we're trying to make sense of all the litigation that we've seen. We at Georgetown have been tracking certainly the more than 30 lawsuits that have been filed over the No Surprises Act since late 2021. On the right hand of this side of the screen there, you can see just how much we have chronicled all these developments for Health Affairs. This is not even a complete accounting of all the different court decisions and new developments, but much of this history can be unpacked in prior posts from this team. But we've really seen a wide array of litigation that I want to walk through today. So of the lawsuits we've been monitoring, there have been constitutional challenges, both to the No Surprises Act statute itself, as well as its implementing rules and guidance. We've seen legal challenges to federal regulations and guidance that I think has had a really destabilizing effect. And in what I would call the most recent wave of litigation over the No Surprises Act, we're starting to see stakeholders sue each other. So payers suing insurance companies suing some of the middlemen and providers that Kenna just talked about, and IDR entities as well. So everybody is in on the litigation these days, it seems. And I think one of our working theories here is that these court challenges have really contributed to a lot of the delays and uncertainty and helped, I think, drive up some of the costs to the IDR system that Kenna was talking about. One thing I will mention too, I'm sort of saying more than 30 lawsuits. That's what we're tracking. That's a conservative number because we're not following all of the lawsuits in that sort of third category of, especially I think providers suing insurance companies. So a conservative estimate there too. And I will say we will not get into the weeds of all the individual decisions here. I think the main takeaway is that we've seen really aggressive litigation and it has been destabilizing. So if you go to the next slide, I want to sort of highlight a bit about the constitutional challenges that we've seen. Big takeaway here is every court has upheld the No Surprises Act against constitutional challenges. That is great news for patients because we have seen court challenges not only try to take down the IDR process, but the patient protections that prohibit providers from sending these surprise out-of-network bills in the first place. If those protections were to be lost, consumers would once again face those bills, that they didn't know that they were going to incur. So those have not been successful, but I think some of those threats remain alive. And so it's very important to sort of keep an eye on what's happening there. Some of the challenges that have been, or the legal arguments, that have been filed against the No Surprises Act have to do with the Fifth Amendment, the Seventh Amendment, lots of arguments about due process, about the right to a jury trial, about takings. Again, no court has really embraced any of those arguments to this date. And we've seen the Second Circuit in particular sort of uniformly reject those kinds of challenges. One of these lawsuits, the lawsuit filed early on in 2021 by Dr. Daniel Haller in New York, was dismissed last year. And then the other two challenges there are still pending. The neurological surgery practice case, we're waiting to see there if that practice asks for full review by the Second Circuit, or if they would like asks for Supreme Court review. I would personally be quite surprised if the Supreme Court were to take that up, but that is an option there. And so will continue to be an issue to watch on the constitutional side. If you go to the next slide, where I think we should spend probably most of our time is the litigation we've seen where providers have sued over federal implementation of the No Surprises Act. So this is not even a full list of all the different challenges that have been filed, but in general, we've seen quite aggressive litigation from doctors, from hospitals, from air ambulance companies, suing over especially the early rules, the interim final rules that were issued in 2021 to implement the No Surprises Act, as well as guidance. So the cases I wanted to highlight here are the ones I think have had the most impact on the IDR process and some of the adjoining regulations. One thing to know, you'll see that most of these cases have been filed in Texas. Those that are, looking at the list, have all been filed before the same district court in the Eastern District of Texas and have all been heard by the same judge, Judge Hoadley. And so perhaps some of the outcomes might not be all that surprising. He has almost uniformly vacated or invalidated the federal rules and ruled in favor of providers, both the Texas Medical Association and LifeNet. And to talk about some of the impact of this, both Texas Medical Association and LifeNet sued either into early 2021 or excuse me, late 2021 or early 2022. The first successful challenge was over the rebuttable presumption, if folks can remember that far back in No Surprises Act lore. That was the first IDR rule that was set aside by Judge Hoadley. And this was the idea, it was a guardrail that the Biden administration had put in place to direct IDR entities to choose the offer closest to the QPA, unless there was essentially a good reason not to. Judge Hoadley vacated that and set that aside. The Biden administration followed up with a second rule that did not adopt the same rebuttable presumption, but had some additional guardrails to say, start with the QPA and then consider additional information. That was still, did not pass muster with Judge Hoadley, who set aside the second IDR rule. That ruling was affirmed by the Fifth Circuit last year, who essentially said that the tri-agencies, the Departments of Health and Human Services, Treasury, and Labor have quite narrow rulemaking authority to govern the IDR process, which I think will make it harder to address some of the issues and challenges even that Kenna was laying out before. There have also been challenges to a second interim final rule the Biden administration issued on the QPA methodology. The arguments there that some of the finer points that were put in that methodology, I think the argument is that they unlawfully sort of depress the QPA itself. And so we've seen challenges both by air ambulance companies and providers to that methodology. That is one that is a live issue. So Judge Hoadley agreed with Texas Medical Association and the district court that went up to the Fifth Circuit in sort of a surprise win, perhaps, if you understand this history for the Biden administration. The Fifth Circuit reversed Judge Kernodle on the QPA methodology, but that ultimately proved a little bit short-lived because just recently the Fifth Circuit vacated that order and decided to put that case before the entire Fifth Circuit panel. So on September 24th, the entire group of Fifth Circuit judges is going to hear the challenge over the QPA methodology. And so we will see what happens from there. The other sort of last litigation I wanted to highlight for this group, which we lovingly refer to as TMA4, was the litigation over guidance on IDR fees and batching. So at one point, the Biden administration increased the fees for IDR, perhaps to, I think both to cover its costs, given what Kenna was just presenting, but perhaps maybe as a deterrent to also, help encourage negotiation before you got to the IDR process. And again, Judge Kernodle agreed with Texas Medical Association there and vacated that and said you needed to use notice and comment rulemaking. So this, I think every sort of thing that was tried at the federal level did kind of run headlong into court decisions there. And I think it's been quite disruptive. And folks, I think you'll hear probably some of this on the panel from experts who are very much in this process. But every time you get one of these court decisions that can be incredibly disruptive, it requires guidance from the federal agencies. It puts a hold on the process. It causes a lot of confusion and uncertainty and takes up resources that could otherwise be used to, for example, streamline the process itself versus dealing with this sort of ping-ponging back and forth in court. So a lot of disruption there just from this handful of cases that we've listed on the screen here. So if you go to the next slide, I do want to spend a little bit of time also on this sort of next generation of litigation that we're seeing over the No Surprises Act. So on the provider side, we're seeing providers who are unhappy with some of the IDR outcomes and awards from the IDR entities, or they have concerns about timely payment from insurance companies. And so they're going to court to try to enforce the IDR awards that they want. We've seen a fair amount of this being brought by air ambulance companies in particular, suing IDR entities or insurers. On the flip side, we're starting to see payers and insurers who are unhappy with the IDR process itself and are concerned about alleged abuses of the IDR process. So insurance companies such as Elevance and Aetna have sued some of the prominent provider groups, some of which Kenna talked about before, that help facilitate the IDR process. A lot of those complaints have focused on the volume of ineligible claims being put through the IDR process and raising real concerns about what that means for systems and making a whole bunch of allegations that are in the piece that was published this morning that folks can read more about. Across all of these issues is really a fundamental question, is when can you go to court under the No Surprises Act? And when are private parties allowed to sue over the independent dispute resolution process itself? This is a pretty complicated question that's being actively decided in courts across the country. The Fifth Circuit has taken that question up twice in challenges filed by air ambulance companies against IDR entities and insurers, and said twice there is no private right of action under the No Surprises Act to sue, and that IDR entities in particular have arbitration immunity under another piece of federal legislation. So they said that twice. There's a Florida District Court case that also reached that conclusion that's on appeal to the 11th Circuit. We could get a decision any day now on that. If the 11th Circuit reaches a different conclusion, you could see a circuit split that would be sort of interesting to navigate and definitely an issue to watch. On the flip side, we've seen a Connecticut District Court rule the other way and find an implied right of action to sue IDR entities and insurance companies by providers. So this is sort of a live issue, one that I think it's very, very important to pay attention to. And certainly during the Biden administration, there's huge implication for everything that Kenna just talked about for the protections under this law for resolving these disputes, if IDR entities in particular can be sued. And so that's one thing to keep in mind. You saw the Department of Justice weighing in many of these cases saying this would completely frustrate the purpose of IDR under the No Surprises Act, because IDR entities do this voluntarily. They're not required to. And so if they are going to face lawsuits after they have issued their awards and done their job, many will predictably sort of abandon the program and not be there to be able to decide these disputes. So big implications coming. Again, a live issue and something important to keep an eye on as we move forward. So if you go to my last slide, I think I have covered all of this already, but one a huge takeaway is we have really seen this aggressive litigation that I think has indelibly shaped how the No Surprises Act has been implemented and will frankly have impacts for years to come on whether the law succeeds in its goals. I think Congress's twin goals of protecting consumers from surprise out-of-network bills and helping hold down healthcare costs and premiums. You know, this law was not supposed to be inflationary in terms of cost, and some of the data that Kenna just laid out, you know, raises some of those concerns, and I think litigation has been a core part of that. And we've already talked about some of the guardrails that have been lifted, and I think some, you know, common sense policies that the Biden administration, the Biden administration tried to put in place that were sort of swiftly invalidated in court. In terms of issues to watch, I'm watching very closely to see what the Trump administration will do and what further action they'll take to implement the No Surprises Act. So far, there's been no shift in litigation defending the law. You know, this was a law signed by President Trump himself in December of 2020. And I think whatever this administration does to try to make changes to everything we just talked about will likely trigger a new wave of litigation, or at a minimum, we'll have to grapple with the sort of complex litigation history that I just laid out. The question about the private right of action and what it means for the IDR process, I've already touched on. And, you know, will, and if so, how quickly any of these cases reach the Supreme Court? We have not seen that yet. There has not really been an appetite to ask for Supreme Court review at this point, but as you can hear me talking, maybe you start to see circuit splits and other reasons that this moves up very, very quickly. So no answers here, but thank you for the opportunity to give a briefing and talk about some of the litigation that we're seeing. And back over to you, Jack.
Thank you, Katie, and thank you, Kenna. Those were great presentations and we got through them right on time. So that's great as well. So I want to take a few audience questions that have been coming in that are sort of specific to these presentations. I'm going to start with one for Kenna. You talked about the component of the cost to the system of payments that go above the QPA, and that is a pretty big component of the cost. And a couple of different people have asked about, is that a fair way to measure a cost to the system, especially if there's some concerns that the QPA is lower than it should be? Can you talk a little bit about that?
Yeah, thanks, Jack. And I welcome your thoughts here too after I give my 2 cents. I think when we do look at that difference between QPA and the prevailing payment amount, that difference might not be entirely attributable to the IDR process, at least in terms of overall additional costs to the healthcare system, because we know some portion of these costs existed prior to the NSA, right? But we do know because of balance billing, this was paid by consumers. But given now that these balance billing protections are in place and consumers are protected, these costs that are specific to the IDR process potentially are adding costs that might not be incurred with different IDR rules, different outcomes, or just a different way to determine what is an appropriate payment for these services. So that would be my first stab at it. But Jack, welcome if you have any additional thoughts there.
Yeah, I would simply add that to the extent that the IDR determinations to the extent that the initial payments by the plans are not challenged by a provider, then that would be the payment they would get. So these are all payments that come due to the IDR system. But Ken is exactly right in saying that if we're trying to compare to what would happen in some theoretical world with a different payment methodology, you know, that could come out differently. I've got one question, Katie, for you, which is, with the various lawsuits that are pending from payers against some of the provider organizations, what's the potential impact on IDR integrity and future enforcement of the system?
Yeah, it's a great question. So I did not go into much detail on this during the presentation. I think what we're seeing from these lawsuits, both the payers against the providers and middlemen that you just mentioned, Jack, but also providers against insurance companies, is folks are trying to figure out a way to get into court. And so what I would say about what the providers are doing is trying to I'll back up. The No Surprises Act incorporated only a very limited number of exceptions for when you can go to court and when an IDR entity's determinations are not binding. So in general, what the IDR decides goes, except in this limited number of circumstances that comes from the Federal Arbitration Act. What we're seeing from this range of lawsuits is folks trying to exploit or fall into one of those categorical exceptions. And so what I think is more interesting perhaps about the lawsuits we're seeing by insurance companies against Halo MD and radiology partners, for example, is they're really alleging a broad scheme of sort of widespread fraud. I'm not saying this isn't the complaint, but widespread fraud. And I think they're really trying to fit into one of those statutory exceptions and make it very clear. What we've seen for some of the providers suing against the insurance companies is claims that are not so egregious, for example. And you've sort of uniformly seen the court say, this is not misrepresentation of a fact. This doesn't rise to the level of something so extreme to get you into court to be able to sue. And so that's one observation I've seen. It feels like a real escalation in the lawsuits against Halo MD and radiology partners. So that to me is a real issue to watch there. I think the courts have sort of said, Congress had a pretty high bar for you to be able to sue and overturn what an IDR entity did. And to me, it seems to be a signal of how frustrated certainly some of the insurance companies are by what has been going on in the IDR process, as borne out by some of the data you all shared.
And Katie, let me follow with another question that's sort of similar, which particularly if there's no private right of action for providers when they're not getting the payment that is due to them as a basis of the IDR determination. What's their alternative? What else can they do?
Yeah, so there have been those lawsuits about untimely payment. I think the ones that I've been referring to are, and even one of the places I've seen some of the providers sue 10 or 15 times against different insurance companies to try to recover the payments they are due from the IDR awards. I think what makes what I'm describing fundamentally different, and a distinction the courts have made, is the attempts to sort of revisit the determination made by the IDR entities versus to kind of enforce the IDR award and the payment itself. And so that's more of the distinction. And then on other issues, complaints about, insurance companies not giving accurate QPA information or timely, some of the requirements that exist under the statute and under regulations, the courts have said, your remedy is with the federal government, not in court. And so I think it also puts a bit of the onus on the Trump administration to go and make some of those course corrections and take enforcement action as they need to.
Right, thank you. And Kenna, one of the questions that came in, you talked a lot about some of the variations across IDR entities, and this questioner wants to know, are the cases randomly assigned to IDR entities, or how does that assignment end up working?
Yeah, so the parties do have some say in which IDR entity will arbitrate their dispute. So I believe the initiating party can select an IDR entity, and then the other party can kind of reject that entity, and there can be a bit of back and forth until they ultimately either settle on an IDR entity or the agency assigns an entity to the case. So that's the overall process, is that the parties do have some say here, and there is an expectation that maybe they would find a middle ground. But we don't have a sense of how often that is playing out amicably, I think. Jack, I don't know if you would have anything to add to that.
No, I think that's about right. There's a random component to it if there's no agreement, but they've already rejected some of the players, so there's not a full random choice. Somebody also asked, is there any evidence of whether the IDR determination amounts in some cases are higher than the original billed charge?
Yeah, that's a good question. In the PUF data, we cannot see the original billed charge, so there's no way for us to know what original amount the provider requested from the plan prior to initiating the open negotiation period, as well as the IDR process.
Yeah, so that's, the law specifically said that billed charges cannot be considered by the IDR system. And so as a result, we don't have that data point available to us because we only have the numbers that made their way through the IDR process. And those are the only numbers available in the public use file. So with
Jack,
that, I think, oh, go
Jack, I
ahead.
would add on that question, at least some of the complaints we're seeing against radiology partners and Halo MD, there is allegations at least that one strategy being used in the IDR process is to, submit higher than billed charges or extremely high out of network rates too. So it is not the same as the data, but I have certainly at least seen some of those allegations coming through in the court filings.
Right, that's very helpful. With that, I want to switch over to our panel, and thanks again to Katie and Kenna for those great presentations and for handling some of these questions. I'm thrilled to be joined for this session by a superb set of panelists to continue this discussion. So the four panelists that we have today are Troy Oxner, who is a fellow at the Rockefeller Institute of Government. More important for today's purpose, he is the former Deputy Superintendent for Health Insurance in the New York State Department of Financial Services. New York was one of the important early state versions of a No Surprises Act. We also have Lindsay Murtaugh. Lindsay spent the last 10 years at CMS in CISIO. Until her recent departure, she served as director of the Market-Wide Regulation Division, and the No Surprises Act was one of her areas of responsibility at CMS. We also have Patrick Pennell. Patrick's the managing director for HHS and CMS operations at Maximus. Maximus is an organization that does serve as an IDR entity for the No Surprises Act, among many other types of arbitration and other kinds of appeals activities that they work with. So his organization is very hands-on in this process. And then fourth, we have Katie Berg. She's Senior Director of Federal Government Affairs with the newly named Blood Cancer United, formerly known to most of us as the Leukemia and Lymphoma Society. Katie's been deeply involved with surprise medical billing policy, both during the congressional debates and since. I'm going to start with an initial question for each panelist, and then we'll mix it up with some broader discussion. And finally, we'll take some questions from the audience. We've got a lot of those questions already in, and you can continue submitting your questions through the Q&A tab at the bottom of your screen. So Troy, I want to start with you and ask you to tell us a little bit about New York's initial use of IDR. Why did New York's stakeholders think it was that an IDR system was the best method, the best method for determining payments, and what adjustments were made in the early years to ensure that the system was fair to both sides?
Oh, thanks so much, Jack. I think why we thought it was the best mess is maybe the better way to put it. But when I got to the insurance department after a decade of suing mostly health insurers for illegal and deceptive business practices at the AG's office, it was all ginned up to tackle the surprise billing problem in New York. And along with the team, we started working with consumer groups and saw that there were a bunch of other attempts to address the issue in other states, primarily through improved transparency, but agreed with the consumers that all those measures fell short. And what we really needed to do is get the consumer out of the middle of this if the consumer did everything they reasonably could to stay in network. Obviously, emergency rooms services, there's nothing you can do, just go to the emergency room. But otherwise, if you did what you could, you take the consumer out. And that was our primary goal. Ideally, we wanted to find a way to also, if we take the consumer out and make the dispute between the insurer and the provider, do three things: compensate the provider reasonably to preserve access to services, do it with minimal administrative costs, and lastly, try to minimize the premium impact. And our initial thought was actually to set a rate that would be the easiest to administer. And we looked at some ideas similar to the QPA that ended up in the federal law. The problem was getting a rate that everybody could agree on. And in New York, I think probably like a lot of states and to some extent on the federal level, we couldn't get a bill passed with strong opposition from the physicians and hospitals on one side or insurers on the other side. And so we needed something everybody could agree on. And that ended up being, independent dispute resolution, because there wasn't a specific rate that everybody could argue about. And the big argument was how to structure the IDR. Insurers initially wanted a full hearing. Doctors thought they'd be outgunned by insurance lawyers and deep pockets. And I think the answer came at the Croton Diner, where I grew up, meeting with a physician friend. They have really good spanakopita, which I highly recommend. But we came up with, the baseball arbitration idea. Everybody submits their best offer, and then independent arbitrator, IDR, picks which. It's administratively less cumbersome. The hope was that it would force everybody to settle and make fair offers. And then the real dispute was around, well, what did the IDR have to consider when they're evaluating which offer to choose? And we ended up with using the usual customary rate, a percentage of the usual customary rate, from this new entity called Fair Health that grew out of a lawsuit by then Attorney General Andrew Cuomo, which I had been involved with when I was at the AG's office. And I won't go into all that, but it's basically using charge data for out-of-network charges from doctors. And that was, and other providers. And that was kind of the basis. And so we ended up with the IDR had to consider the Fair Health provider charge data, but could consider anything else. And that was what we needed to appease the insurers. And so it allowed the insurers to submit whatever data they wanted, and then the IDR would make their own decision. And we kept a really close eye on it in the early years. I know when I was reviewing rate increases, because like most states, we in New York, had to approve any premium rate increases, at least from our regulated insurers. And, ask the insurers, is this something that you see and your actuaries see is driving a lot of premium rate? And it wasn't back then. And I will say, even today, it's not something that insurers are putting in as the basis for major rate increases. That's still pharmacy costs and hospital consolidation are the big things driving health insurance premium rate increases in New York. But clearly, you've identified a problem with the venture capital, and I guess you can thank New York for getting consumers out of the middle, and blame New York for us to solve that legislative problem, creating this IDR model that ended up, kind of being adopted first by a number of other states and then nationally.
Thanks, Troy. That's really an interesting backdrop for some of what we're dealing with today. Lindsay, I want to turn to you next. In the federal IDR system, giving your vantage point on the inside until recently, are there steps that should be taken to better ensure fair outcomes?
I think absolutely. But when I think about your question, Jack, I think it's important to really break it into two parts. Because what is a fair outcome? I don't think there's a lot of agreement on that, which may be part of the problem and part of why we see that inconsistency. But I think the first part I want to talk about is ineligible disputes. Kenna presented a lot of information on that, and I think that is an area where we can agree. In almost all cases, I believe there's at least one area where people are complaining about which should be eligible. But in general, if the dispute is ineligible for the federal IDR process, I think any time there's a payment determination made, that is going to be an unfair outcome. And so I think as kind of a starting point, certainly there should be additional steps taken to make sure only disputes that are actually eligible for the federal IDR process reach payment determination. Kenna talked a little bit about that process, and I think you at the beginning also made some mentions about which disputes are eligible, but this is a very complex question that IDREs have to tackle and are not reimbursed for. First off, Jack, you mentioned that it's only certain items and services that are eligible. It's also only items and services that are covered under certain types of coverage, primarily sort of major medical, private coverage, anything through Medicare Advantage, Medicaid, those don't belong in at all. Um, if it's covered by the NSA, you still have this additional layer of is the final payment determination something that belongs in the federal IDR, or is it actually subject to a specified state law like the law that Troy was just talking about? If that's the case, then that dispute should be dismissed and it should be sent to the state process. And then on top of all that, if it is actually eligible for the federal process, there are a number of procedural steps that need to be taken, like open negotiation needs to be properly initiated and the like before it goes to the federal IDR process. So there's lots of things that an IDR entity needs to look at, but also the provider and the payer before the dispute is even initiated or kind of addressed for the non-initiating party. And so I think really focusing there will take us many steps towards more fair outcomes. The departments, and from my kind of seat on the inside for the past almost 5 years, I watched as the departments really took a lot of steps and worked very closely with IDREs, and Patrick may be able to speak more to that, to really address problems relating to eligibility. The data Kenna presented showed the sort of significant decrease in the backlog as the agencies worked with the IDREs to kind of clear that backlog, clear the cases faster, make the eligibility determinations, and then also to educate plans and providers and issuers in terms of what actually belongs. The agency also took a number of steps to sort of automate the portal through which the disputes are submitted, so that some of the ineligible cases just are automatically going to be kind of kicked out or not even able to be submitted. And also did training efforts working with the IDREs, as I think I sort of alluded to. But there are limits to what could be done and has been done. And so one of the other things that the agencies did as they worked on to improve the portal and work with the various parties was to propose the Independent Dispute Resolution Operations Rule. And one of the things that rule targeted was trying to make sure there's better communication between the parties, so that the information is available for all the different parties to really figure out how to submit the cases and whether the cases should be submitted. So just as one example, this seems basic, but it actually turns out to be very hard for providers sometimes to know who they have a dispute with. Particularly for when they're dealing with a self-funded plan rather than an issuer that's regulated at the state level. They might just have the name of the TPA and they don't know if that's a TPA that's working with company A or company B, but they are not able to combine those disputes if they're different, if they're with different companies, even if it's, United or Humana or whoever administering that coverage. And so one of the things that the rule does is to try to take steps to make sure that the payers are providing that critical information to providers. Without that information, providers aren't really able to submit sort of key information to the IDR portal. And it's also really hard for the IDR portal to take steps to automatically kind of kick some of these ineligible disputes out. So I think, those long-term improvements, finalizing the IDR operations rule, could really go far in making sure the unfair outcomes that come from ineligible disputes are sort of minimized. In the long term, I'll just put it out there while I have the floor. I think, we are in a place where there are standardized transactions for the vast majority of communications between plans and providers, but the No Surprises Act was passed, and the standardized communications have not caught up. And so trying to make sure a lot of those communications are happening in a standardized fashion will also, I think, go a long ways. So that's the ineligible disputes. The other thing I think, though, is really thinking about how we ensure fair outcomes with disputes that actually belong in the federal IDR process. And I think that's a lot harder. I think that, it's clear some of the outcomes certainly don't seem fair. They don't really pass the sniff test, when you're looking at something that is orders of magnitude higher than the billed charge. That doesn't seem quite right. And also looking at the QPA, while there are questions about whether the QPA it was artificially deflated, I think it's still a good starting point. And when you see something that is so much higher, I think we heard 1,030% higher. That doesn't sound fair. And so I think that while we may not have consensus on what is actually fair, it does certainly seem that there is a problem here, and the inconsistency is also a problem. But as Katie talked about, I think the litigation really constrains what the departments can do here. When we were considering how to build the IDR process, I think it seemed pretty reasonable that an arbitrator would sort of start by thinking about what's a fair value for this item or service, and then look at the details of a specific case. So a fair value, by a fair value, I mean a fair value for that service on average. And then they might think about the specifics of the case at hand for whether it's should be a higher payment than the average fair market value or a lower payment. And the original rules created that so-called rebuttable presumption, and then the amended rules sort of just said start here. And I think our idea was that there's some sort of anchor that all IDREs would use to start the analysis. And maybe the QPA, the qualifying payment amount, wasn't the perfect anchor, but it was an anchor. And what Troy just shared about the New York one, in New York, there's a very similar process, and they get to look at the usual and customary charges. In the federal process, unfortunately, we have a situation where the IDREs have been told you can't start with the QPA. And you're also not allowed to consider other things that might be sort of a good starting point, like the usual and customary charge. You can't consider billed charges. You also can't consider what would be paid by a public payer. So ultimately, there may be a lot of variability between the different IDR entities in terms of sort of where they start in thinking about what might be a fair market value, and then how they weigh the information that they get from the parties in terms of severity or expertise of the provider, and what they have to base their decision on in terms of what the best payment offer is. And I think until you have a little bit more consistency across how the IDREs can approach that question of what the appropriate payment determination is, you're going to continue to see inconsistent outcomes and unfair outcomes as well. Unfortunately, though, I think that the court decisions have really tied the agency's hands here, so it may be that congressional action is really needed here. There may still be some actions that the agencies can take on the edges, but I think without an anchor, it's pretty hard. We could definitely talk more about their options, but I mean, one just idea to throw out there, and is maybe there are some ways to look at what the original offers are and sort of cap them at something that, like the IDR process, the way that the IDR process sort of fits in with the big picture in the NSA, it's sort of the last resort. The parties are supposed to be working together beforehand. The issuer should be offering something that they think is a reasonable payment amount. There's this concept of open negotiation, which, as far as we can tell, isn't really doing much right now. It would be ideal if we can get to a place where somehow the parties are forced to do a little bit more negotiation earlier, and maybe are more limited in what they can bring to the IDR process. Maybe they can't throw out a crazy offer, either a high or low ball offer, when they actually get to the IDR process, but maybe it can be based on something that's going on earlier.
Thanks, Lindsay. Those are a lot of really provocative and interesting thoughts. I'm going to spin a little bit off of one of your points for Patrick. Patrick, you're representing an IDR entity, and Lindsay was just talking about some of the ways that you don't have provided for you various kinds of anchor numbers, that you have to work with what the two parties bring to you. So do you feel like the IDR entities get the right amount of information from the two parties to make a fair decision? Are there other resources or other kind of anchor information that would facilitate decision making?
So it's a good question. I think it depends on what's provided, right? And most of the time, it's the initiating party that's going to be providing the information to support their offer, right? And the arbitrator is typically only seeing those two data points and not getting to evaluate them in the context of wider, market rates, for a specific area, unless those are provided by one of the parties. The initiating party probably not incentivized to do that. And the non-initiating party probably just relying, most of the time, the non-initiating parties are relying on the QPA. But broadening that spectrum and not making it a binary of, one offer that might be on the lower end and then one offer that might be quite on the other end, I think would result in certainly the perception of a more fair outcome, as we were talking about earlier. But I think that's one of the things that we have to consider. What Lindsay was just saying. The IDR process was supposed to be an exceptions process, right? It was supposed to be, okay, we've had the conversation and most things get resolved there, but sometimes it's just irreconcilable, and we need to bring in this objective third party to look over it. I think that's where we're missing the work to get to more, I don't want to say realistic numbers, but to get to a more common number between the two parties. I think there was the assumption that would be happening there, and that seems to sort of being circumvented and just waited out to, to sort of shunt things to the IDR.
Thanks. No, that's a really interesting perspective. Katie, I want to go to you next and just really ask, how much should we be worried about the frequency and magnitude of the provider wins that we showed in our data? And how do these IDR decisions affect consumers?
Yeah, I mean, I think first and foremost, like, patients have been thoroughly protected by the NSA in terms of surprise bill. So it has been a huge victory for our community when our call centers used to just be hot with phones ringing off the hook about, how am I going to afford this $50,000 surprise bill? And so I think the other side of that is that we need to be really cognizant of the inflationary implications for, a huge volume of claims in this space. And so I think we heard Patrick and Lindsay say, like, this is supposed to be an item of last resort. And so the fact that we had HHS estimating that the mid 40,000 IDR disputes were anticipated each year, and we're in the millions, I think is really indicative or explanatory for, like, that this is a great deal for a lot of people who are initiating claims. And we've seen the vast majority of those coming from providers. And so this volume of disputes is disproportionately high. Success rates for providers is, not just successful, it's lucrative. And that money that insurers pay doesn't just come out of thin air. Like, this will reappear in other places. And I think the place that we are really concerned about as an organization that represents cancer patients and high cost medical care anyway, is like, there is no such thing as a self-pay cancer patient. They have to be able to afford their monthly premium. They have to be able to afford their co-pays. And, like, I will be the first one to admit on this call that the insurance market right now is going through a tumultuous time on a variety of levels. But this was meant to shield consumers, both in terms of surprise bills and their premiums. And so when we see this high volume, we have a great concern about how much longer in a high cost universe will all patients be able to afford their premiums. And I'll say too, like, I'm really concerned about the engagement of private equity. I'll say, as a patient and consumer advocate and representative, the time that I hear private equity and healthcare go together really gives me chills, because frequently that means that there are poor outcomes for patients. So as we've seen the total number of disputes increase, if we've seen private equity engagement, if we've seen a high number of provider wins with higher and higher and higher QP, like multiples of the QPA, I think all of this activity will ultimately translate into greater costs for patients and consumers. And that's why we really care about kind of this back half of the No Surprises Act, despite the significant successes of the front half, which is that like base level shielding patients and consumers from undeserved surprise medical bills.
So thank you, Katie. It's nice to bring it back to the consumer, which is, as I said at the beginning, at least one of the points where everybody in the system has agreed that was a great goal, and that does seem to be one of the goals we've achieved. But we're still concerned about about these IDR outcomes, the frequency of use of the system. And I've heard today a few different suggestions, maybe the need, Lindsay talked about maybe the need for some kind of data points that are separate from what the parties are bringing to the system. What means would there be of better getting the two parties to communicate and talk to each other? And the thought, in the design that informal negotiation period, that first 30 days would be something that would yield to a lot of compromises. And if your offers were close enough to each other, you could pretty much say, hey, we'll split the difference and go home. Um, are these the right answers for trying to improve the process? Are there other things? Do we need more sort of oversight of the IDREs? Are there concerns about how those decisions are made? What are the other things that should be done to lower the volume of cases and to make everybody walk away feeling more like the decisions that are coming out of the IDREs are fair ones? I'll throw that out to the group.
Well, I'll jump in and just say, I mean, I think probably, maybe that a legislative fix is needed to give CMS the authority it needs to, uh, you know, more specifically direct how that analysis is going to go. Having said that, I do know in New York, one of our concerns was looking at the IDR decisions, and that a lot of them seem to be just consistently going with the UCR, usual customary rate, because that was in the statute as something that they had to consider, although they can also consider all these other factors. And, it would depend, as Patrick noted, it depends what the parties bring to the table. But reminding what we ended up doing was having to remind the IDR agents that, it wasn't just the UCR rate, that there were other things and they should be considering. And that seemed to help get them to consider other things other than that UCR payment. So in other words, and I think it sounds like CMS has already been trying to do that, but really communicating with the IDR agents may have at least some limited help.
I definitely think introducing a um, uh, additional data point to the review process, to things that go to the IDR, that is not biased would help deal with the fairness issue, because you've got two parties, you have two offers, one has to win. It's going to be unfair to the other party because the overwhelming likelihood is that someone didn't show up with an incredibly fair offer, right? We are people, and we are going to make the offer that's in our best interest, right? So two opposing sides, you're probably not going to see one offering a number closer to the middle. So that would definitely help if there was sort of a broader approach, additional context, I guess, in which the arbitrator is functioning, right? Because when these things come to the arbitrator, all they know is there's a payment dispute, okay? And then all they learn about that payment dispute is what is told to them by the two parties. So I think having a broader context could be one way to shift to a more fair outcome, with the understanding that, when one party has to lose, it's always going to be seen as unfair. But I do think, Jack, the first part of your question, it really is two different things, right? One is, how do we address inconsistency in the IDR process? But then there's also just looking before that and saying, like, are we overusing the IDR process? And you'll see this a lot I work on a wide variety of programs that have these sort of administrative steps in review of a disputed issue, right? And what you will tend to see, like just sort of like water, going to the lowest point, you will see people rushing to the part of the process where they feel like they can get the most beneficial outcome for themselves, right? And I think it's pretty clear from the data that were being presented earlier that you see that from providers, especially with the support they're getting from the industry that's sort of built up around this to move these through, they might not be incentivized to spend as much time in an open negotiation. I don't know that for sure. I don't have any data to support that, but I think we have a compelling piece of leading data in just the much greater use of the dispute resolution process than anyone anticipated, and that's probably just what we're seeing. We're seeing an encouragement to a behavior that gets you to your desired outcome faster.
One of the issues that Lindsay raised was this whole, and that Kenna talked about early on, was this whole question of ineligible cases. And, we have seen a decline in the number of cases determined to be ineligible as they're being judged by the IDREs. We haven't really seen any drop in the number of cases that plans are challenging as ineligible, and we've seen some of the lawsuits talk about even whether there was a strategy. Is there any good solution to that? I mean, Lindsay, you talked about some of the processes. Should this be taken out and be done more as a CMS or federal agency function, or contracted out separately from the IDREs? There's an issue of payment, because if the IDRE rules the case ineligible, they don't collect their IDRE entity fees. How do we get around this question of just the volume of cases that's driven by ineligible cases?
I'm happy to jump in first on this one.
Yeah.
I mean, I think that there has been a learning curve, but to the extent that there are some actors out there who are using the kind of threat of ineligible cases as a negotiating tactic. And I think that to the extent changes can be made to allow the agency to take action, and this I think could probably be done administratively, but take action when they are aware of providers who are knowingly abusing the system, that could be helpful. Right now, there really isn't any leverage there, other than sort of the bully pulpit that I'm aware of. And so giving the agencies kind of maybe through rulemaking or something, taking steps to allow them to address those bad actors would certainly be helpful. But I think there is, as I mentioned earlier, there are communication challenges, and where there are also certainly ineligible cases that are just getting submitted, and it's not through any bad actors, it's just poor information. And I think, as finalizing the IDR operations rule would certainly be a great step in that direction to fill in some of the gaps. I mentioned kind of standardizing communications further through electronic standards. That would be a huge step as well. I'm personally a little less in the camp of trying to get the agencies to take over the IDR the eligibility determinations themselves. The IDR operations rule did actually propose some situations in which the agency would take over that process, sort of as a backstop when there was a backlog or whatever. I think that there's been a huge growth, and Patrick can probably speak to this more in terms of IDRE's ability to do that themselves, and the agencies provide a lot of support to help make that possible. And so I think that is probably less critical right now, but certainly making sure that IDREs have a way to get paid for the time that they're spending on eligibility determinations could be very helpful.
Yeah, I like the idea, Jack, of a separate contractor that does the eligibility. That introduces some problems, though, right? Because now that's additional cost, that's additional administrative costs, and you're also introducing a new bottleneck for the process, and it's right at the front of the process. So then I think operationally that starts to create some downflow problems as well. I do think the agency has taken good steps toward that. Lindsay alluded earlier to some changes in the portal, where now you're entering the data for the cooling off period, which is a leading reason for ineligibility. And we really have seen the fall off there. So I think more investment in some relatively simple steps up front. Just another one that comes up, fairly frequently that is simple is this appropriate for federal, or is it actually supposed to be going for state arbitration, right? Having that identified by the portal up front would also cut out a lot of those, and those sort of changes carry a very low administrative cost that you get a return on investment every single instance of a new dispute request. So.
I want to start bringing in some audience questions into the mix here, and we had a couple of different. We had a lot of good questions from the audience, and we're not going to get to nearly any of them. We may try to comment on a few of those afterwards in some format. But we had a couple of different questions talking about the role of private equity, and I know Katie, you brought that up in your remarks. I guess I'm thinking about two sides of that. One is, why do we think, so many of these cases are coming out of private equity backed providers? And, what is the concern, right? Is there some way that we should be addressing that?
I'm happy to take a stab at that. I don't think that there's anything intrinsically wrong with private equity. I think there's lots of problems from a profit-driven system that's across the board. That said, I think the data really bears out very clearly that there is a high success rate, a high volume of claims, and a high volume of high reward claims being driven by a relatively small market section of the market. And so I think that is one of the things that we really need to be thoughtful about in terms of how the system is being utilized, and how the inflationary impacts of which the NSA was designed to contain costs, not only in terms of preventing surprise bills, but also in terms of making sure that it was a saver when it was scored by Congress. And so I think that is really important to keep in mind. So I think that would be my 2 cents on the role of private equity in the market, which is to say, if there's a process to be maximized there, that's great. But there's also, private equity is a profit-driven strategy. It's used across models everywhere. And so, I think that there's a lot of concern with how that might ultimately play out in terms of patient costs that are borne by people who are sick.
One of our audience members raised the question of whether, if we're really seeing such a domination of the process by this relative handful of provider organizations, does that mean that there's a lot of other providers out there, the smaller sort of more localized provider organizations, that are not able, either because of the administrative cost or other reasons, knowledge, to participate in the system? And whether the rise of some of these middlemen organizations could actually play a role in giving some of those providers, smaller providers, more access to the system.
I think we definitely see that in terms of disputes coming in. We see very few from small providers, and when we do, there's often a lot of handholding that has to happen because they don't understand the process. It might be the only time they're using it in a quarter or even a year, and so it's a lot to learn for one case. But if you're a small practice, that that one claim may carry a significant amount of your revenue. So definitely that has created a strong demand for an intermediary agency that can help prep your case, explain the process to you, and do that. And you definitely see a lot more use from smaller providers that are coming through a middleman than just coming by themselves. So.
And I think it's also very early in the process. I mean, you have these private equity firms that had a lot of extra resources to sort of test out the program and see how the disputes were falling. When you look at various states that took, a range of approaches in passing state laws to deal with surprise billing, I think one thing you notice is that the frequency with which whatever the dispute process is used really depends on who's winning. And if it's the providers, some states have experienced basically exponential growth in how frequently their dispute process is used. We're still relatively early on. The private equity firms may have been the ones who figured it out. We are seeing these middlemen types of companies popping up, advertising that they can help with the IDR process. I don't know that they'll continue to be quite as dominant, I guess, as they have been, as other out-of-network providers may begin to leverage the IDR process, and we may continue to see big increases in the numbers.
Yeah, I mean, I think that's part of the playoff of that. If there's better access to the broader provider community, that may just totally increase the number of cases that we see in the process. We had another audience question about use of artificial intelligence, maybe in the IDR arbitration process. Patrick, do you get a sense? I don't know, in your own organization, are there ways to leverage AI to help with cases or determining eligibility? And is that something we should look at as a positive, or something we should be concerned about as a negative?
Well, I could talk about that for an hour. So it's one of my most common topics. So let me reduce it to a very short answer. Yes, there is a good use. Eligibility is a great place to do it because there shouldn't be, in the vast majority of eligibility instances, there should be no gray area, right? It should be the facts are the facts, it's eligible or it's not eligible. That's a great place to use an AI or ML solution to rapidly resolve those cases. And that a stronger application of that could be the sort of the contractor, the intake contractor that we were talking about early. That's the sort of thing that could be handled by an AI solution. In terms of using it in other parts of the process, I'm not as strong of a proponent of AI right now in a decision-making process that has gray areas that require a judgment, that sort of thing. So I think it could be used later in the process, but I think there would have to be a lot more consideration about how that's done. Eligibility is a very easy target as an AI use case.
Thank you. Any others that want to chime in on the value or issues with AI? If not, let me turn to another question. What do we think is the effect of this provider win rate that we now have, 2 years of evidence of win rates? I mean, I can imagine several potential impacts that it would have. If there's a good chance providers win, then that could bring on more cases. Does that lead to IDR entities, maybe thinking about, is this the right sort of collective outcome? The process is to look at one case at a time. But is there some reflection on this win rate that leads to some adjustment?
I can start there as someone who's fairly close to fairly close to it. First, I don't know that it's terribly surprising that we see this. To Lindsay's point, it is early. And programs like this, a few years may seem like a long time to us, but it's really not when you look when you think about it. They can take a lot of time to deeply penetrate a market and reach all eligible parties, right? So we are seeing early trends. But what we are seeing are, the vast majority of the time, the provider is the initiating party. They have a very strong interest in the case and are much more likely to provide more compelling documentation, right? They're sort of they're the more active party. And if the plan is more passive, as the non-initiating party, which again, the vast majority of the time they are, in an arbitration process, the less passive party is unlikely to be the victor, right? They're unlikely to be the choice. So I don't know that it's necessarily shocking that we see that, but I do think that there's an opportunity to look across IDRs and make sure that there is consistency in how people are coming to those outcomes, right? I don't think that there's necessarily anything inaccurate about a heavy provider slant at this point, just based on the way that the program is set up. But I do think having some sort of inter-reviewer reliability audit to make sure that every IDR is largely arriving at those conclusions the same way would be appropriate, right? So then we know that we're seeing more of a trend of use rather than a trend of the evaluation of the claims coming in.
Any reactions from others on the panel?
I would just echo that. I think that, I've heard allegations that parties have tested basically the same identical claims and gotten different determinations. I think some level of standardization there would be really helpful. And I think that if you also look at the patterns, because there is that role and for the parties to get to choose the actual IDRE, my assumption is that it's, the IDREs have an incentive to side with the provider simply because that's who's initiating the disputes. There is the ability for the planner issuer to veto the selection, but if the planner issuer is less active, the IDRE is likely going to be bringing in more business if they are seen as a provider-friendly IDRE, and that seems problematic.
Yeah,
Interesting point.
I want to speak on that as well, because that's IDREs are very different companies, right? Like there's what, 15 or so now. They're all varying sizes, varying organizations, that sort of thing. My company, Maximus, we're a fairly large company. We've been around for a very long time. We're heavily audited. We have a very strong ethics system and sort of thing like that, right? So our arbitrators don't even know how we get paid on this contract, right? They wouldn't even understand that there is a benefit to one way or the other. But how do you ensure that everywhere? And I mean, we've had similar thoughts when we look at data and you see, oh, an IDRE is being selected by this provider, and there's 90% plus win rate. It does seem odd, even as another person working in the industry. It seems odd. We're not the kind of company where that's likely to happen just because of our size and the ethics programs we have in place, our own quality reviews and stuff like that. But and I'm not even saying that it does. But when you see those data points, it makes you think, right? You go, okay. And so I would not assume, just knowing from how we're organized, I would not assume that any IDRE perceives an incentive in siding with the provider, right? But when you see the data trending the way it is, you do want to see that evaluated. You're right. Well, we should at least check, right? And so I definitely think that there should be some sort of check on that as well, because I've had similar thoughts when I look at the data and you see things getting in the 95 plus area. You're like, okay, that merits a look. Certainly internally it would merit a look, right? If we saw that, we'd be like, wow, is this provider just really, really good? What's happening here? So yeah.
And I should be very clear, since I was at CMS, that I am not implying that I've seen anything, but like you, Patrick, I feel like it merits a look.
Yeah.
Troy, you look like you wanted to add something. We're right about at time.
No, just that I have to say I'm a little surprised at the no surprises bill, because I thought going into it, maybe like a lot of others and like was predicted, that if anything, it was going to be the doctors who would be at a disadvantage. The insurers have, a big war chest, to have lawyers, have kind of an ability to really gear up for this. And I guess I didn't really think through the private equity piece of it, or didn't see, and this was back in 2015 when we originally passed ours, so 10 years ago. Uh, but clearly there's a concern, and I think it's up to us working with government to try and reform it, because there does seem to be something askew.
Well, thanks to the whole panel. This has been a terrific discussion. You've all been great. And I want to turn it back to Laura. Laura.
All right. So yes, I want to echo Jack's thanks. This has been a really great session. Really appreciate the participation of everyone. Including the audience, we've still got a really good sized audience hanging on at the very end here, so we appreciate that. There were a huge number of questions and some really, really good questions that have come through. So we will have to, I'll confer with the speakers about what we might want to do with that. We appreciate you sending those in. So with that, I just want to mention again, as the slide has gone up, there are a couple of forefront articles that may answer some of the questions that we didn't get to today. So please take a look at those. I want to again thank Arnold Ventures for their support of this event today. And I want to mention a couple of other upcoming events that we hope you'll join us for. On September 3rd from 1 to 4 Eastern, we are having an event featuring authors of the papers in our September theme issue, which is on the opioid crisis. On September 17th at 2 o'clock Eastern, we are hosting an event with Joshua Sharfstein of Johns Hopkins and Brendan Solaner of Brown University, again about the opioid crisis. And on September 23rd at 1 o'clock Eastern, we're holding yet another virtual event exploring the current state of prior authorization. And that is moderated by Mark Fendrick of the University of Michigan. And that is an exclusive event for Health Affairs Insiders. And if you are not one of those, we hope you will check out the Health Affairs Insider program. Today's event was open broadly, again, thanks to the support of the Arnold Ventures. You can find more information about these events and other upcoming events on our website at healthaffairs.org on the events tab. I want to just reiterate that shortly, probably tomorrow, I think that the slides and the video recording from today's event will be up on our website in the events tab. And with that, I just want to again thank all the speakers, the panelists, and our audience for joining in. And with that, we are adjourned for the day. Thank you.